I'm here at University College London with Simon Waddington from the Gene Transfer Group. Simon, would you like to tell us a little bit about your role here?
I lead the Gene Transfer Technology Group at the Institute for Women's Health at University College London.
Could you tell us a bit about the research that you've done with gene therapy?
Sure. So we're looking at gene therapy for single gene disorders that affect mainly babies and children. So these are quite often very severe diseases that might affect the brain or might affect coagulation of the blood, but diseases that are so early in onset that they cause the injury or death even by the age of 4 or 5 years of age.
What have been the main successes of gene therapy?
So I think actually is that there have been quite a few over the past decade, and although they've been quite sporadic, they've been really quite encouraging to the rest of the gene therapy community. The first was in the year 2000 when the bubble boys, the boys with X-linked severe combined immune deficiency, so this is an immune disease, they were cured because their bone marrow was taken out of them, a corrected version of the gene was put into the bone marrow, then the bone marrow injected back into them again. And I think actually now the oldest of these is around 11 years old. So that was the first major success, and there have been several since, quite a few actually at University College London as well. One success was in 2008, or one trial that was a success was in 2008, and that was run by Robin Alley and James Bainbridge at the Institute of Ophthalmology. And here they were treating an inherited blindness whereby the teenage years the patients actually were unable to see in dim light. And so Professors Alley and Bainbridge, they were able to inject a gene therapy vector into the back of the retina of these patients to deliver a corrected version of the gene that partially restored their night vision. And then I think actually is that really excitingly this year as a joint venture between University College London and St Jude's in Memphis, Tennessee, there was the first partial success for treating haemophilia B. So in these patients, they're deficient in the gene encoding the coagulation factor, factor 9. And so these patients, they have to inject themselves every 3 days or a week with the coagulation factor, the protein concentrate or the recombinant protein. And in this gene therapy trial, they were injected intravenously with a gene therapy vector called an adeno-associated virus, and this partially reconstituted the factor 9 gene in their liver. And so several of these patients now have stopped injecting themselves with recombinant protein and are no longer developing spontaneous bleeds. So this, I think, actually is probably the first instance of a single intravenous injection treating what actually is really a systemic disease.
With these successes, what are the challenges that you face with gene therapy?
Well, pretty much the ones that we've come across in our own research are the ones that really affect the whole of the gene therapy community. So one of the major problems is that an adult develops an immune response to either the gene therapy vector, which is often a virus or based upon a virus, or the immune response against the gene, the protein that's been encoded by the gene that's delivered. So, of course, the adult immune system has already seen, it's encountered a lot of viruses in normal life. And because a lot of gene therapy vectors are based upon viruses, therefore, is that quite a lot of adults have pre-existing immunity. And so this has been one problem why you've got to select patients in the clinical trials who don't have this pre-existing immunity. One of the other things actually that has been problematic in gene therapy is being able to develop vectors that target the correct cells or tissues or organs. So obviously is that each genetic disease affects a certain category or group of different cells or tissues. So the art in this is to be able to target your gene expression to those specific cells. For example, with haemophilia B, is that what you really want is the expression coming from the hepatocytes in the liver. And this was what was achieved actually in this gene therapy trial.
How are the problems of gene therapy overcoming these examples?
So the way that people have been approaching the adult trials is either to inject the gene therapy vector into an area where there is immune privilege, where you don't get an immune response. And so therefore for the blindness trials, here they were injecting into the eye, where you don't get such an immune response. For the people with haemophilia B, is that they were choosing people who didn't have a pre-existing immunity to the virus vector. And so there was a greater likelihood that these people would not develop an immune response. What we're actually looking at is injecting the vectors very early in life. And so the earlier that you go, the more likely you are to be able to deliver the genes without getting an immune response.
Could these solutions be applied to other areas of gene therapy, or are they all separate?
So the problem of immune response and the problem of targeting certain tissues and organs, these are things that have to be addressed for every instance of gene therapy for a single gene disorder. But on top of this, some diseases have unique problems in terms of delivery. So for example, again going back to the inherited blindness, it's relatively easy, and I'm saying this of course, I'm not doing it myself, to actually to get the vector into the subretinal space to be able to target the cells that have been affected. Whereas, for example, in cystic fibrosis, it's proving to be very hard to get the gene therapy vector into the correct cells in the lungs that would reverse at least the lung defect. And there are numerous reasons for this, including the fact that your lungs are built to be very efficient at clearing viruses away from your lungs. And more so a problem with CF patients, because they tend to have thicker mucus, and so therefore it's more difficult to get the gene therapy penetrated. Also with, for example, cystic fibrosis, this is a disease that affects the lungs and the intestines and other organs, and so therefore to treat the entire condition would mean targeting the gene to quite a variety of different tissues. Whereas going back to the treatment for haemophilia B, actually is that if you can just get the genes into the liver, then actually is that you can get the systemic effect, because the liver can then secrete the coagulation factor protein. So it's very much is that each disease poses a unique set of problems beyond those that affect all of gene therapy.
What diseases are hoping to find a cure in gene therapy?
It's an evolution of gene therapy approaches built upon the successes that have already occurred over the past decade. So, for example, the early successes with immune deficiencies then brought successes with diseases such as X-linked adrenoleukodystrophy. So that's the disease that's featured in the film Lorenzo's Oil. So this is a bone marrow disease, but actually affects the brain. And so this whole area of research is looking at treatments for different types of bone marrow-based diseases. And those, of course, then extend out to things like thalassemia and sickle cell anemia, which affect quite a high proportion of people. But then in terms of the research that's recently shown, or the clinical trials that have recently shown success with haemophilia B, this now means that it opens up a window for potential treatment for a variety of different metabolic diseases that quite often affect children as well. And so anything where you need expression in the liver, or where you can get the protein expressed from the liver, is now game for treatment with gene therapy.
For these different diseases, what areas are actually being researched at the moment?
There are many diseases that are being researched, certainly at a preclinical stage. So people are doing research into urea cycle enzyme defects. They're looking into things called organic acidemias. People are looking into gene therapy for muscular dystrophy, for sickle cell anemia, for thalassemia. I think actually is that for nearly every single gene disorder, is that there are groups of people working on looking at gene therapy for it. And of course, people aren't just limiting themselves to single gene disorders, is that people are looking at potential gene therapy for HIV infection, for hepatitis, for cardiovascular disease, for infectious diseases such as tuberculosis and malaria. And then, of course, is that people are looking at using gene therapy vectors for anti-cancer treatment, and also for using them as a means of vaccination against infectious disease. So I think that for every disease class is that people are looking into genetic therapy as a way forward.
How realistic do you think it would be to say that these diseases would be treated by gene therapy?
Again, they're going to fall on a disease by disease basis. So, for example, is that now people are looking at different types of blindness, and based upon the success that we've seen so far, I think that these treatments are going to be quite likely. Whereas other diseases such as muscular dystrophy, because you're having to target a large number of muscle groups, these may actually be more difficult. But one thing we've seen over the past 5 years is that we're now able to make much higher quality gene therapy vectors at much higher concentrations, and because they are purer, is that we're able to improve their efficiency and reduce the immunogenicity. So things that would have seemed unfeasible 5 years ago might actually be reasonable in the next 5 years. For example, there were some recent studies, preclinical studies, using a different type of adeno-associated virus. And they've seen that by an intravenous injection, a single intravenous injection, is that you can hit the central and peripheral nervous system. So therefore, there is some hope actually is that using this class of vectors is that you might be able to treat some of the neurodegenerative diseases. And this is the way it goes actually, is as the vectors develop, is that we're always turning new corners and seeing new treatments and new treatment modalities.
Are there any ethical concerns regarding gene therapy?
I think people worry, firstly, about the fact that it's not reversible, certainly for the single gene disorders, is that once you've injected your vector, that then produces essentially a transgenic person, and you can't go back on that single injection. So therefore, there may be problems down the line from expression of this gene that we hadn't anticipated. And it's not like a medicine that you can put someone on and take someone off if you're seeing side effects. So there is a problem here over the concerns over what long-term effects would be. But the only way that we're going to see this, of course, is by actually doing it and seeing what happens. Another concern that some people have, or at least a misunderstanding that some people have, is that gene therapy is not only a cure for the patient, but also for the patient's children as well. But that isn't the intention of gene therapy, and it's not within the scope of gene therapy, and it's not legal. So therefore, actually, the intention is only to treat the patient, but then to leave the germline unaffected.